All right.
Yeah. Have you registered?
Please mute yourself. Is that okay? All right. So I've described this scenario, a normal day. If someone just walks in, 52-year-old man, just complains of chest discomfort, he sits down, slumps on the floor, and this man is not breathing. This man's heart cannot be, pulses cannot be felt, and heart cannot be felt as well. You are called
Yes.
in to help resuscitate this man, and what do you do next? What you do next will determine if this man goes home or becomes another statistic. All right? All right, so let's go to the foundational concepts of basic life support. These concepts should be at your hand tips if you want to become someone who is so adept or good at basic life support. High quality chest compressions or high quality CPR improves a person's chances of survival. That's something that should be behind your brain or always in your mind. And if you talk about high quality CPR, we are talking about starting chest compressions within 10 seconds of noticing someone having cardiac arrest. Is that okay? Push hard and fast. You are pushing at least, that's you're compressing the chest at least 100 to 120 chest compressions per minute, allowing full chest recall or complete chest recall. You minimize interruptions. All interruptions should be minimized to less than 10 seconds, and you give effective breath. So effective breath does not mean giving excessive breath or giving breath that will actually cause gastric irritation and gastric inflation. If you do that, gastric irritation and gastric inflation will what? Lead to pushing of abdominal content and the aspiration of the patient. The patient will die from aspiration and your CPR will be a waste of time. So effective breath means that you are doing CPR. Sorry, effective breath means that you are giving any breath that causes the chest to rise. Are we together? So effective breath is any breath that causes the chest to rise. Is that okay? All right. So that's effective breath. Okay. All right. So the cardiac arrest chain of survival. Early recognition and emergency activation. Very, very indispensable. Early recognition, emergency activation. You start your chest compressions or you start your high quality CPR as I've defined already in the previous slides. You start it within less than 10 seconds of what noticing the person to have undergone cardiac arrest, or 10 seconds when you actually called on the scene. It may be that the person had undergone cardiac arrest, sometime, like few minutes or so, but when you were called on the scene, you should start in less than 10 seconds. Is that okay? You start your high quality chest compressions. All right, so rapid defibrillation, basic and advanced emergency medical services, then advanced life support and post-arrest care. All right, so early recognition and emergency activation, high quality CPR, defibrillation, early defibrillation, very important, advanced resuscitation, post-cardiac arrest care, and then we have recovery and survivorship. Is that okay? So let's define high quality CPR again. So high quality CPR can be defined as a rate or a chest compressions rate of 100 to 120 chest compressions per minute. Okay, and the depth should be 5 to 6 centimeters. That is 1/3 of the AP diameter of the chest of an adult. So this one is for the adults. 1/3 of the AP diameter of the chest of an adult. Allow full chest recoil or complete chest recoil. Minimize interruptions to less than 10 seconds. Change compressors every 2 minutes. Avoid excessive ventilation. So the ventilation, a good ventilation is any ventilation that causes chest to rise without any gastric inflation or gastric irritation. Are we together? All right. So for adult BLS algorithm, first thing you have to do is to verify the scene safety. When you are called to the scene as a practitioner, no matter who you are in the health sector, verify your scene safety. Why is it so important to verify scene safety? This is because if you don't verify scene safety, you can become a victim or you can become a casualty, you can become a patient in that particular scene. Let's say you are called to a scene, an accident scene, and the people there are trying to pour water on the patient, trying to do whatever they have learned wrongly to do to a patient who has undergone cardiac arrest, and you arrive on the scene and you don't make sure the scene is safe for you. By the time you realize maybe somebody is trying to pour water and the bucket just left the hand and hit your head. By the time you realize you have become unconscious with subarachnoid and subdural hemorrhage or some hemorrhage, intracranial hemorrhage. Do you understand? And you trying to save the patient have become a patient at that particular scene. So you are rather becoming a patient rather than becoming the savior. So verify your scene safety. If you're on the ward, make sure that the floor is not slippery. Make sure that there are no needles and sharps on the floor that could hurt you or hurt someone. Because if you get a needle prick, you don't know whether the patient is a retropositive Hep B, Hep C. You have to then run and go and make sure that you go and do all these tests after seeking consent from anyone that the pin may have been used on to make sure that you yourself are safe. By the time you come, the patient is far gone. So verifying scene safety, as minor as it looks, is very, very important to make sure that you yourself, you are safe to perform your CPR. If the scene is not safe, please don't go ahead and perform your CPR. Okay? If your scene is not safe, don't go ahead because you can be a victim. All right? So you check responsiveness. How do you check responsiveness? You check responsiveness by checking the patient is breathing and also by palpating. You see, the trachea is here and the sternocleidomastoid muscle is here. In between them is the carotid artery. So you check the carotid pulse. So you checking for the breathing of the patient and also checking for the pulse or the carotid pulse of the patient should not be more than 10 seconds. Is that okay? Verifying scene safety, checking for the responsiveness of the patient and calling for help should be less than 10 seconds, all in all. Okay, so that you have very few limitations or few time limitations for you to start your high quality CPR. Is that okay? So the third thing is to call for help. I mean, some of you are in advanced world where calling for help, if you call the ambulance in less than 10 minutes, sometimes 5 minutes, ambulance will arrive. But most of us or some of us who are in Africa, where when you call the national ambulance, it will take hours before they arrive. So calling for help can just be calling a taxi nearby or calling a friend, a colleague nearby. That is if you are outside the hospital setting. Calling a friend or colleague nearby who is very close to you is also a health professional. Is it understandable? Uh-huh. So the reason why I brought in calling a taxi, let's say that you are in somewhere, you are the only health professional. You have to get the person to a hospital as soon as possible. As you are performing your high quality chest compressions, you get a taxi, then you move the person in it as fast as possible to the nearest hospital so that proper CPR will be continued there. It may seem not feasible or not the best, but in some parts of the world, this is the best remedy you can give to someone who is in heart failure. Because if you are trying to depend on national ambulance or any other specialized care, in quotes, it won't arrive to you at all. So it's just wisdom to use what you have. Okay. So you check breathing and check your pulse, and you start CPR. If no pulse, it's failed. Okay. So for the adult BLS algorithm, 30 chest compressions to 2 breaths. That's something you have to put in mind, 30 to 2. You attach your AED or defibrillator, immediately it's made available. In the advanced world, they have defibrillators in city centers and some specialized or some strategic points in the society. So when you ask someone, you can just ask a street person, get me a defibrillator. Within some few minutes, the person will bring it because it's just there. But in Africa, defibrillators are not there like that. Even in some hospitals, there are no defibrillators. Do you get it? So when you talk about getting defibrillator in the hospital setting, if your hospital has it, within some few minutes, someone can get it for you, and the scene will look so perfect. But if you are outside the hospital setting, as I said, try to get the patient as fast as possible to the nearest hospital where care can be administered and you too can be helped by other health professionals. Because basic life support is actually a teamwork if you want the work to be done very well. Is that okay? Are we together? All right. So shock if indicated and continuous CPR for 2 minutes and then we reassess. Is that okay? All right. So let's I hope you are all following. I want to see some comments in the comment section to show that we are all following, even as I try to. All right. So even as I try to get, all right. So this is the algorithm by American Heart Association. Is that okay? So you verify your scene safety. That's the first thing you do. Okay, verify scene safety. You check for responsiveness. Okay, as I said, you check for responsiveness by checking the carotid pulse. Okay, very easy between your trachea and the sternocleidomastoid muscle, that big muscle here. Between it, there's a triangle there. When you put your hand there, you can even check the carotid pulse is there. Shout for nearby help for someone to come and help you. It's not necessarily the person, if you're outside the hospital setting, the person shouldn't necessarily be a health professional. Okay, any person can come in to come and help you. So far, the person can coordinate and is ready to listen. So you can just direct the person, please perform chest compressions. You teach the person as you perform your chest compressions, then the person does the same thing. So far the person is doing it in the right way, you can just go ahead and be giving your breath in support. So 30 to 2, is that okay? Activate emergency response system. That can be a call to the national ambulance, a call to a taxi to come. If you're in a preferred setting, you just activate the national emergency response system and the EMS in some advanced setting will just come to your aid with their specialized care. Okay, so send someone to get you an AED. In the hospital setting, send someone to get an AED. Is that okay? So cardiac arrest management without a defibrillator or defibrillation is actually a waste of time because you have to get rid of that abnormal cardiac rhythms or abnormal electrical currents or waves that is in the heart that may have caused the cardiac arrest. Unless there's no shock advised by the defibrillator. Is that okay? So far as it's a particular, the cause of the cardiac arrest is because of a abnormal electrical waves in the heart. You have to make sure you defibrillate. So AEDs are very important. Is that okay? I mean, I can't stress on it that much. All right, so you look for breathing or no, you look for no breathing. If there's no breathing and there's only gasping, remember gasping is not breathing. Is that okay? If the patient is gasping, he's not breathing. Okay, gasping is said to be agonal breath. So if a patient comes to you in the hospital center and the patient is gasping, don't think that's normal breathing. It means get your tools together and start your CPR. So if a patient is not breathing or only gasping, all right, or only gasping, check for pulse simultaneously. If pulse is definitely felt within 10 seconds, then you know that yes, there's pulse. So then if the breathing is abnormal, okay, but pulse is felt, like this part. Sorry, I'm trying to get rid of this. All right. Okay. So if pulse is felt, but breathing is abnormal, so you provide your breath, one breath every 6 seconds, okay? So 10 breaths in a minute. Is that okay? So one breath every 6 seconds. So you are providing 10 breaths in a minute. Is that okay? Okay, so check for the pulse every 2 minutes. If no pulse, start CPR. If you suspect opioid overdose, administer naloxone, okay, which is an opioid antagonist, if available. So opioid overdose have become very, very common on the streets of most part of the world. So when you see a patient, especially outside, and you know this patient is, people are giving a brief history that, oh, this man, he abuses medications or he abuses drugs. Please let someone get naloxone for you. It can be from a nearby pharmacy or something, and give it immediately. Naloxone has no known side effects. So even if the person does not abuse drugs and maybe somebody just wrongly mentioned that bit of the history, if you give naloxone, it won't cause any harm. But if the person abuses drugs, it will be like magic. He will recover immediately after the drug and the naloxone is given to the person. Okay. All right. So that is if the breathing is what? If the breathing is abnormal but pulse is felt. Is that okay? All right. So in case the breathing is, hello, can I be heard? Okay.
Yes, we can hear you.
All right. So in case there's normal breathing and pulse too is felt, then you monitor until advanced care arrives. Is that okay? So if you met the patient has collapsed, the patient has had cardiac arrest, according to the people on the scene. But you check the pulse and you came in, you verified scene safety, everything was fine. You check responsiveness, you check the pulse, and you check the breathing, and realize that there's breathing and there's pulse. You still call for nearby help and you activated the emergency response system and you send someone for AED. Is that okay? Because these patients, people on the scene were like, oh, this man had cardiac arrest. Please don't leave the patient if you still felt breath and you feel that the patient is breathing and also you felt a pulse. Monitor the patient till advanced care arrives. Very, very indispensable because this patient can go into cardiac arrest soon. Don't leave the patient just like that. Is that okay? So if there's no breathing and only gasping, okay, only gasping, pulse not felt. No breathing, only gasping, pulse not felt. What do you do? So gasping is the same as what not breathing because I've explained to you that gasping is agonal breath, which also means that the patient is in cardiac arrest. So that when you start your CPR, you perform cycles of 30 to 2 breath, 30 chest compressions to 2 breath. Is that okay? Use your AED or defibrillator as soon as it's available. Okay? If you suspect opioid overdose, consider opioid antagonist, which is the naloxone. There's also nalfenamines, but it's not as popular as naloxone. Is that okay? So you get your naloxone and you give it immediately, 0.4 milligram, and it's like magic. If you suspect it, patients will just jack back to life like that. So when the AED arrives, is that okay? It means that you have to check your rhythm. You connect your AED. The AED stands for automated external defibrillator. Every instruction is on it. Where to attach this, where to attach that, where to not attach this and that. Do you understand what I'm trying to say? Okay, so once the AED arrives, then you have to attach it. Okay, so once it's attached, if the AED tells you this is a shockable rhythm, you give one shock and you start your CPR for 2 minutes. One thing you also have to note in your mind is that CPR is done for 2 minutes. So after 2 minutes, the AED will prompt you. Okay? The AED will prompt you immediately that you have to what? Give your, you have to allow for another rhythm check. Then the AED will check again the rhythm. If it's a shockable rhythm, then it will tell you to what, give another shock. Then you start your CPR immediately. So if it's a non-shockable rhythm, okay. So if it's a non-shockable rhythm over here, resume CPR immediately for 2 minutes until prompted by AED. Is that okay? Defibrillator to allow AED or defibrillator to allow for rhythm check. So you continue until advanced life support professional take over or the person starts to move. Is that okay? So that's how you are supposed to go by it. If it's a non-shockable rhythm, it's CPR only. You do your CPR 30 to 2 breath, 30 to 2. As I said, high quality CPR. What is high quality CPR? The five most important aspects. So you compress the chest hard and fast, 100 to 120 chest compressions per minute. You allow for full chest recoil. Is that okay? You give a breath that is adequate enough to allow for the chest to rise without inflating the stomach to lead to what? Gastric content aspiration. Is that okay? So these three things are very, very important. allowing for full recoil, 100 to 120 cycles per minute, giving adequate ventilation, compressing at least 5 to 6 centimeters, that is 1/3 of the AP diameter, or the AP dimensions of the anterior posterior dimension of the chest of the adult patient. Is that okay? So once you are doing all these things, you know that you are doing high quality chest compressions. Why is allowing full recoil very important? If you are compressing on the chest of the patient like this, you are doing your chest compressions and you don't allow full recoil. Remember that the heart is an organ that beats on it when it compresses and it relaxes. It contracts and relaxes. So you are doing the work of the heart. Is that okay? So if you allow full chest recoil, you allow the heart to refill, then you compress it. You allow the heart to refill, then you compress it. So that is what you are making sure that there's the oxygenated blood gets to vital organs, which includes what? The heart itself, the brain, the kidney. Very important. So allowing full chest recoil is very important. If you don't allow full chest recoil, you are doing this. It means that the heart is not being refilled properly. So the cardiac output will reduce drastically. Do you understand? You are doing this. So the heart is not allowed to be refilled. Then you just compare the cardiac output will be so reduced drastically, and the blood will not get to the brain. It won't get to perfuse even the heart itself. So allowing full chest recoil cannot be overemphasized if you want to have high quality CPR done on your patient. So this is one of the major reasons why we don't have high success of CPR on our wards and in most hospitals in Ghana, because most people do not allow full chest recoil. Only CPR or chest compressions alone can save a patient. Only chest compressions alone, especially the adults, because the commonest cause of cardiac arrest in adults is from a cardiac origin, or is from the heart or conditions of the heart. But in children, it's normally respiratory conditions that causes cardiac arrest in them. So once there's adequate chest compressions and there's high quality CPR, an adult is more likely to survive from a cardiac arrest. Is that okay? I hope I've made it simple and very much understandable enough. All right, so let's move on. So this is the full thing. Okay, verify scene safety. You do this. Abnormal breathing by pulse is felt. 1 breath every 6 seconds. You are targeting 10 breaths per minute. No breathing or gasping, and pulse is not felt. Then you come to here. You start your CPR 30 to 2 breaths. If when AED comes, you attach your AED. If you suspect naloxone, if you suspect opioid abuse, you give your naloxone. If everything is normal, pulse and breathing is normal, you monitor until advanced care arrives. Is that okay? So once you are doing your CPR, for the ones that you didn't feel your pulse, you didn't see any breathing, once AED arrives, you check the rhythm. If it's shockable, give your shock. You continue your CPR for 2 whole minutes. Is that okay? And you allow for checking of the rhythm again. If it is shockable, you repeat it again until an advanced life support professional takes over, or the person starts to move. Is that okay? If it's not shockable, you continue your CPR for 2 minutes and you check your rhythm again after 2 minutes. You do this until advanced life support person arrives. Okay? This is something you have to put in your mind. Is that okay? So the question goes this way: when do I stop CPR? 1, you stop CPR when the advanced life support person arrives. So in the setting of Africa, or some setting where resources are so depleted or resources are not available, you stop CPR when you hand over patient to the hospital staff. Okay, so you stop your CPR over there. You stop CPR when you are exhausted. Is that okay? So when you are very tired and you can't continue, you stop your CPR, because you can also put yourself at risk as well. Is that okay? So you stop CPR when you are also exhausted, and you have to stop the CPR. Okay. So you stop CPR when the patient starts moving, or the patient is now responding. So you stop your CPR, but you don't let the patient go. You hand over the patient again to an advanced life support so that they will do post cardiac arrest care. Is that okay? So you stop CPR then. So stopping CPR is actually dependent on the person who is doing the CPR, because people have a lot of energy. Some people have a lot of energy. They can go for 30, 1 hour, and it depends on the person doing the CPR. Is that okay? All right. And also, you stop CPR if there's a written note by the patient that do not resuscitate. Some people have a written note. So maybe you are doing your CPR and the uncle or the son of the patient comes to you and it tells you, check the side of this patient, and there's a note there that do not resuscitate if I have cardiac arrest. You stop the CPR immediately because you can be found guilty by the law. Okay, so that's one of the things that should make you stop CPR. Is that okay? All right. So cardiac arrest management in pregnancy. All right, so this is a very specialized aspect. So it's a multidisciplinary approach. Why multidisciplinary approach? You need obstetrician to be present. You need anesthetist to be present. You need a midwife present. You need a nurse present. You need a lab technician alerted, or the blood bank alerted and ready. Okay, the blood bank alerted and ready. You need someone to administer medications as well. Okay. So one of the important things you put in mind when it comes to cardiac arrest in pregnant women, the management is lateral uterine displacement. It's so indispensable, because if you do that, you minimize or you reduce to compression. So you do the lateral uterine displacement in every pregnant woman whose the level of the uterus is either at the level of the umbilicus, okay, or 20 weeks and above. So the patient is 20 weeks and above, or if you don't know the gestational age, the uterus is at the level of the umbilicus. Always do lateral uterine displacement. How do you do it? You either let someone manually push the uterus to the left lateral side, okay, to relieve the cardiac compression. You push the uterus to the left lateral side, okay, or you can displace the uterus by putting a board at the right hip of the patient to displace the uterus to the left side. Is that okay? So you can do either of this way. Then the goal is to make sure that you perform a resuscitative delivery. At first, it used to be called peripartum or perimortem delivery. Now it's a resuscitative delivery within 5 minutes of CPR. Okay, so once you deliver the baby within 5 minutes, then it means there's no to cover compressions, and then you can do your proper chest compressions. Okay, is that okay? So you secure airway in pregnancy. Airway securing in pregnancy is so much important, because pregnancy itself can lead to a lot of edema, and the airway can be edematous. And remember that you are trying to get the minimal air to the lungs as much as possible. So getting a secured airway is very important. That's why anesthetist should be present in your team to either do a secure laryngeal mask airway or do endotracheal intubation or intubate the patient. Is that okay? Then you continue with the ALS management. It's so important. I can't overemphasize that as well. All right, so there's the full thing. Okay, when it comes to pregnant women, this is what you have to do. You start your high quality CPR. Okay. Start your high quality CPR. Provide continuous left lateral uterine displacement when the fundal height is at or above the umbilical. That's 20 weeks and above the fundal height. Use AED or defibrillator when indicated. Okay. Activate cardiac arrest in pregnancy team. So once you notice it and you started your left lateral uterine displacement and you are doing your CPR, activate the team. The team for pregnant women who go into cardiac arrest, that team, make sure the team is activated. Then you optimize resuscitative delivery. So prioritize early airway management. As I said, very indispensable. Place IV above the diaphragm. Why do you have to place IV cannula above the diaphragm? Because you want to get the medications. You have to let it bypass the air to cover compressions. If it is below the diaphragm, you have to pass through the aorta from below. Okay, so you have sometimes to cover compressions can delay the movement of the medication. So it should be above the diaphragm. So it should be at the upper extremities of the patient. I hope we are learning, we are together. Is that okay? If the patient is receiving magnesium sulfate, stop immediately and give calcium. Why do you have to stop max sulfate? Max sulfate is a smooth muscle relaxer. It will relax your muscle, the smooth muscle, so it will relax the heart and leads to what? Poor cardiac output and hypotension. Remember, you are trying to get the heart to compress, and you're giving something that is a smooth muscle relaxer and will lead to poor cardiac output. Once you are giving the person max sulfate, or the person was on magnesium before the cardiac arrest happened, give its antagonist, which is the calcium. Give calcium immediately. Okay. Then detach fetal monitors and activate massive blood transfusion protocol if amniotic fluid embolism is suspected. You activate massive blood transfusion protocol. Okay, so on this arm, you prepare for resuscitative delivery if the founder heart is at or above the umbilicus. So the goal is to perform resuscitative delivery within 5 minutes if no return of spontaneous circulation. That ROSC means here return of spontaneous circulation. Okay, then you continue your ALS, that's advanced life support. So when the baby is delivered, you have to hand over the baby to the neonatal team. That's why you need a neonatologist or a pediatrician in your team. What are the commonest causes of cardiac arrest in pregnant women? Anesthetic complications. Recently, there was a patient that we did a cesarean section for. So the patient was on we had to do a GA because of, we were suspecting that this patient had some abrupt shoe. So you had to do a GA. But the anesthetist had given petidine up to a level, and he didn't know that it was an overdose for that particular patient. Okay, so anesthetic complication is very, very important. So remember, I said opioid overdose. What do you give? Naloxone. Immediately he gave naloxone, the patient just jerked back to life. It's just like a miracle. So naloxone, especially on the streets, especially if a patient comes from theater and has cardiac arrest. Naloxone. Okay, so the second cause of commonest cardiac arrest in pregnant women is bleeding. Yes, the third one is, I can't overemphasize bleeding enough. Recently, a patient passed at Konfanochi Teaching Hospital because of what? PBH, that is bleeding. Okay, cardiac arrest, that bleeding. And this patient had been bleeding from the periphery for very long. By the time we got to Konfanochi Teaching Hospital, it was too late. All right, so other cardiovascular complications like a myocardial infection, so some drugs, as I've mentioned, some medications, okay? All right, so embolic phenomenon like amniotic fluid embolism and pulmonary embolism, fever, okay, can cause it, and generalized causes like H's and T's. So we have the H's and T's. So those of you will be joining or who are willing to actually do the full training on BLS and ACLS, there's a presentation on H's and T's. You go into details of all these things I'm trying to teach today. So this is just surface to just introduce you to it. But you being here will help you very, very much and give you an advantage over someone who wasn't here for just this basic expose. Is that okay? Hypertension is so much important when it comes to cardiac arrest in pregnant women. Are you following? I want to see some comments in the chat so that we know that everyone is following, everyone is here. If you are enjoying it so far, let's see some comments in the chat as well. All right, so let's come to children, cardiac arrest management in children. I mean, there are some of you who are on the pediatric blocks or pediatric departments. There's a particular protocol change when it comes to children. So for children, the high quality CPR, remember in adults, you do your hand like this, then you compress on the lower half of the sternum in the middle of the chest. That's where you do your CPR, 30 to 2 breath. 30 to 2 breath, okay? So the breath, I didn't mention this on the breath, you can do mouth to mouth, or we have a pocket mask. So those of you who have a pocket mask, pocket face mask, you can also use that one. With the inception or with the advent of COVID-19, it's not actually advisable to do mouth to mouth giving of breath for patients. Is that okay? So you can do your chest compressions, as I said, the most important thing that actually determine the survival of patients. Till you get to the ward or you get to the hospital where there's an ambu bag and you can use that one as well. Okay, but if it's somebody you know, a relative you know, you can do your mouth to mouth. If you have a pocket mask, you can use it as well. So in children, what makes children so special? In children, the chest compression, you use your arm around the chest, so 2 fingers on the middle of the chest with arm around the chest. And the depth of the compressions is 4 to 5 centimeters. Remember, adult is 5 to 6 centimeters. Children is what 4 to 5 centimeters. Is that okay? So normally so let me be more specific. So for neonates, that's when you use the hand around the chest with 2 fingers in the middle of the chest for neonates. Depth, you are targeting 4 to 5 centimeters. Okay. Remember, the rate is the same, 100 to 120 chest compressions per minute. But for infants and children who are a bit well built, you should use the heel of your hand. Okay, this part of your hand. Then you compress at the middle lower segment of the chest, the sternum. So you compress at the same rate. Is that okay? 100 to 120 chest compressions per minute. Is that okay? All right. So remember, I didn't mention the 2 fingers. Now it's not recommended by American Association again. Okay. So what is recommended is the 2 that you are seeing here. Please keep that in mind for children. So the children, what the algorithm for pediatric basic life support? The same first 2 stages: verify scene safety, check responsiveness, shout for help, activate emergency response system. Is that okay? But it changes from here. No breathing or gasping. So abnormal breathing, but pulse is felt. For children, what do? You open the airway, reposition the head of the child, you provide breath. Remember, in adults, you were doing 1 breath every 6 seconds, targeting 10 breaths per minute. But in children, you are doing 1 breath every 2 to 3 seconds. So when you've been on a pediatric or neonatal ward for some time or NICU for some time, you're hearing them saying breathe 2, 3, breathe 2, 3. So you are targeting breath every 2 to 3 seconds. Your target is 20 to 30 breaths per minute. Okay, so it's changing here, 20 to 30 breaths per minute for the pediatric. Okay. Assess the pulse rate of the child every 2 minutes. And if you suspect opioid overdose, give your naloxone again. It's the same as adults for here. No normal breathing, normal pulse, you monitor. Okay, so advanced care arise. So notice here, there's another change also here. Is that okay? All right, so if the heart rate of the child is less than 60 with signs of poor perfusion, despite oxygenation and ventilation, please, you move on to here. So what comes here will come up later. Okay, all right. So what will be here is that you start your CPR. It will come here, but the next slide will show it. Okay, so remember that for a child, you are feeling the pulse. Okay, though you are feeling the pulse, it's less than 60 beats per minute, and the signs of poor perfusion, start your CPR. So in a pediatric case, you feeling the pulse does not rule out the fact that you don't start CPR. You have to start if it is less than 60 beats per minute, and there are signs of poor perfusion. So if it is more than 60 beats per minute, you continue giving your breath for 2 minutes and check your pulse every 2 minutes. Is that okay? So this is the next slide. Okay, if you witness the collapse of the child, so remember, if you witness the collapse of the child, there's some changes. If you witness it, it means that you have some few seconds to do what? Activate emergency response system and retrieve your AED. Then you come back to come and do your CPR. But if you didn't witness the sudden collapse or the cardiac arrest of the child, start your CPR for 2 minutes before going back to take your AED and defibrillator. That's if you are the only one around. I don't know whether you get what I'm trying to say. So there's a child maybe in a society on the street, somebody called you as a doctor in the society or as the nurse in the society, a paramedic in the society. My child just had this condition and he's not breathing. I can't feel a pulse, and you come on the scene. What do you have to do? When you arrived, did you witness the collapse? If you didn't witness the collapse, start your CPR immediately. Do your 2 minutes chest compressions, okay? 30 to 2 breaths if you are the only one. If you have 2 rescuers, 15 to 2 breaths for the child. So that's also changes in a child. 15 to 2 breaths for 2 rescuers. But if you are the only one, 2 rescuers, 15 to 2 breaths. If you are the only one, 30 to 2 breaths, okay? You do it for 2 minutes before you go and get your AED or activate the emergency response system. Because the reason is because if it is the cardiac arrest has taken time before you arrived and you further delay, the child will not make it because the heart and the mind will not be perfused if you delay. Is that okay? But if you witness the collapse, then you have some few seconds to just activate emergency response system and then retrieve your AED, then come to do your CPR immediately. Is that okay? If you suspect opioid overdose, give your naloxone. Why do you have to suspect opioid overdose in pediatrics? Because some parents use a lot of opioid. Tramadol is now very, very common on the streets. So a child may have, in a one way or the other, come across it and mistakenly swallowed it and went into cardiac arrest. So if you suspect it, if the parent is someone who uses these drugs, please give your naloxone. It has no side effects, as I said. After 2 minutes, if still alone, activate emergency response system and get your defibrillator, if not already done. Okay? But if you get help, then you do 15 to 2 breaths. Is that okay? All right. So once the AUD arrives or the defibrillator arrives and you check for the rhythm, it's a shockable rhythm, give one shock, then you resume your CPR immediately for 2 minutes. So in 2 minutes, you are expecting that you do 5 cycles of chest compressions and 2 breaths. That's what you're expecting that you do, okay? Within that 2 minutes. Then you continue until the PALS professionals arrive, or the infant starts to move, or you get tired, okay? Or you get very exhausted. So PALS arrive, infants start to move, you get very exhausted, or you hand over to a specialized team. If no shockable rhythm, resume your CPR immediately for 2 minutes until prompted by AED to allow rhythm check again. Then you continue to PALS team arrive, that the pediatric advanced life support professionals arrive to take over from you when the child starts moving. All right, so this is the same thing in the home. All right, so for double rescuers for pediatrics, it's also a change. It's 15 chest compressions to 2 breaths, double rescuers. Is that okay? But for the adults, no matter the number of rescuers around, it's still 30 chest compressions to 2 breaths. Why are they doing 15 to 2 breaths for pediatric? Because at the end, you get 30 to 4 breaths. And I already told you that for pediatric, respiratory arrest or respiratory causes are the commonest cause of cardiac arrest in pediatrics. So you have to make sure you are giving enough breath. And even the current teaching says that when you see a child in cardiac arrest, you should give breath before you even start chest compressions. Because you have something we call rescue breath. Okay, you give your rescue breath. Some teaching says you give 5 rescue breaths. Some will say 10 rescue breaths before you even start your chest compressions. It's okay. Because for pediatrics, rescue breaths are so important. Just the breath can revive the child. Okay. All right. So choking in adults. This one you will not handle it. It will be handled or spoken about in the full training course. So there are more technical things you learn from here as well. All right. So choking, how you go about the choking in pediatrics and also in adults. So drowning to be handled in the full training course as well. Okay. So let's talk about AEDs. All right. So how do you use your AED? AED stands for automated external defibrillator. So you attach the AED, has a lot of instructions on it already. You can quickly go through within some 2 seconds. The instructions will be at a glance. You just know what to do. Attach your AED. It will teach you where to attach it. Okay, turn on the AED first. Okay, you attach the AED. You analyze the AED. You analyze the rhythm and tell you this is a shockable rhythm or this is not a shockable rhythm or shock is advised. Okay, then immediately, if shock is not advised, you continue your CPR. If shock is advised, you give your shock. Before you give your shock, always alert the team clear so that everybody moves away from the patient and the bed, not even touching the metal of the bed, because the electric current that is going to correct the abnormal rhythms in the heart can pass through the metals in the bed and enter into you, the practitioner, and can lead to you having cardiac arrest. Remember, this electric current, if it gets to interact with your normal electric activity in your heart, it can lead to what? Cardiac arrest in a normal person. So before you give any shock, always scream clear so that everyone moves away from the patient and you give the shock. And then you start your CPR again, then you reassess after 2 minutes. So this is how the AED is used. Very simple. So team rules, as I've already mentioned, CPR is very, very team related activity. You can't do a high quality CPR cannot be done by one individual. It's a teamwork, and that also to get the work done effectively. You need a team leader, you need a chest compressor. Remember, every 2 minutes, you have to change chest compressors, okay? Every 2 minutes, so that you avoid fatigue, because you need depth, you need full recoil, you need depth, you need full recoil, depth, full recoil. Is that okay? So airway manager, you need someone to manage your airway, give your breath as well. Defibrillator operator, you need a drug nurse, someone who will give medication in case you have to give naloxone. You need a recorder or a timekeeper. This role looks very, very unattractive, but it's very important because the recorder will tell the team that you are spending you are delaying more than 10 seconds. So you have to up your game because you're not supposed to delay more than 10 seconds in high quality CPR. Okay, for high quality CPR, no interruptions more than 10 seconds is allowed in high quality CPR. Is that okay? You have to give your adequate breath, hard, fast chest compressions, 100 to 120, allow full recoil, no interruptions more than 10 seconds. Is that okay? And you change your chest compressors every 2 minutes. So these 5 things makes your high quality CPR. I hope I'm communicating. Let me know if I'm communicating. You guys are learning a lot, okay? All right, so the recorder is so important. All right, as we bring the session to an end, I'll be taking some questions as well. You can start putting your questions in the comment section. Is that okay? All right, so let's take a real life scenario, a real case scenario. So a 52-year-old collapses at the workplace, is unresponsive and not breathing, and the nurse calls you and your team. So the nurse started the CPR. We had a good nurse on that particular shift, okay? The nurse started the CPR before he even came in. That's a very good nurse. And she has attached the defibrillator. Is that okay? And then the defibrillator is reading this. So who can tell me what this is? You can open your microphone and just tell me what this is. So if you see this reading, what do you think it is? So who can tell me what this is? Is someone ready to tell me what this is? Okay, so can someone tell me if it's a shockable reading or a non-shockable reading? I don't want it to be like someone was about to speak and then I went on to obstruct the person from speaking. So please let me know. You can also let me know in the comments. Okay.
Shockable.
So it's shockable, that's true, and it is ventricular fibrillation as I think Gloria is the one who put it. So it's ventricular fibrillation. Okay. So this ventricular fibrillation, and it's a shockable rhythm. Okay. So your shock was given. You gave your shock, and then there was a return of spontaneous circulation, which is ROX, achieved after 2 cycles. Then the patient was transferred to the ICU, and always remember, early CPR saves life, and you have to make sure that you are doing high quality CPR at all times. Is that okay? All right. So those who do the full section will get to know about shockable and non-shockable rhythm, how to understand, how to identify them. There will be a full session on ECG, okay, and how to read an ECG. So it's going to be an in-depth teaching for those who will be doing the full training, ACLS and BLS training section, okay? All right, so I want us to watch this video shortly. Please, can you see the screen?
Are you all right? Are you all right? Go along too.
So remember, before, let's look at something very important here. You see, she looked around, so she verified the scene safety. She looked around first to verify scene safety. And then what did she do? Let me say, did we all see it, please? Verifying scene safety, very important. Then she checked for responses.
Go along too.
And then she activated emergency response system. Okay?
Unresponsive and not breathing victim. I start CPR. Get me an AED.
Hello, I'm with an unresponsive person. He's not breathing. We started CPR.
One.
Do you all see the hand placement and how she did the hands? Very important. Very, very important.
2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8.
So do you see the depth and how she allows full chest recall? It's deliberately allowing full chest recall. And she's counting so that she doesn't miss anything. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Why is it very good to end at 10? Because sometimes you are going 11, 12, 13, 14. It makes it more stressful. So you end at 10, 10, 10. So the third 10, you know that is 30. Then you go and what? You give your 2 breaths. Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8.
Are we appreciating the full chest recall?
9, 9, 30. Three, 4, 5.
Patient care chest. Plug in pad connector next to flashing light.
Then clear?
So do you see, do not touch the patient, stand clear. Eh? This is not just a gimmick. This is something that can save your life as a practitioner. Okay.
Stop advised. Charging. Stay clear of patient.
Everybody stand clear.
Deliver shock now. Press the orange button.
Shock.
Shock delivered.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7. Everybody stand clear.
Air shock advised.
I take over. 1, 2, 3, 4, 5. 1.
So do you see how they handed over immediately the professionals arrived? So that's how it's supposed to be. So there's this video that I normally show to people in the paid food section, but let me just, I mean, you guys are wonderful people, so let me just show it to you. I think you learn a lot from it as well. That's the last thing we do. Okay. All right, so few minutes.
Instead of telling you about how amazing Toonby really is, why don't I just show you? Let's say we want a bee explaining the law of gravity. And boom, in 1 second, you have everything created. And I'm not talking...
Our heart is an amazing organ. It works hard for us every second of every day, delivering blood and oxygen to every cell in our body.
Can you see it?
But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively and blood flow stops. Without any intervention, The brain, vital organs, Our heart is an amazing organ. It works hard for us every second of every day, delivering blood and oxygen to every cell in our body. But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively,
Please, can we
and
see?
blood flow stops. Without any
Yeah.
intervention, the brain, vital organs,
Okay.
and our heart will begin to die. Beginning CPR is the person's only chance of survival. Brain damage will start to set in within 4 minutes, and after 10 minutes, brain damage becomes irreversible. The power to save a life is truly in your hands. Performing CPR accomplishes 2 critical things. 1, compressions move oxygenated blood to the brain to keep the brain alive. And 2, compressions keep blood and oxygen moving to the heart muscle itself, so that it has the best chance of resuming a normal electrical rhythm after a shock is delivered. As you begin compressions, you are creating an artificial pump and doing the work of the heart manually. With each good, effective compression, you are building up pressure in the system, which will move blood around the heart and up to the...
Please, are we appreciating the reason for the full chest recall here and the depth and everything? This is a video that will show you details of what's happening inside the human. Okay.
brain. It does take time to get the blood moving with CPR, so it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out.
So 2 inches is the same as 5 to 6 centimeters on outlet. Okay. All right. That's 1/3 the AP dimension of the chest. All right.
Pushing at a rate of 100 to 120 compressions per minute is necessary to keep blood pumping. Let's see what happens when we take our hands off the chest. Blood stops moving to the brain. It is for this reason that if you are taking your hands off the chest to deliver breaths or switching roles, it is critical to minimize time off the chest. Watch what happens when we don't.
So when you are switching roles, you minimize to less than 10 seconds because when you leave it, the blood starts coming back from the brain. So this patient can become brain dead. Okay? Start moving back from the brain. Is that okay?
Don't push deep enough. Blood does not reach the brain. The same is true if we do not push fast enough. Watch what happens when we push too fast. The heart does not have time to refill with blood. Therefore, not enough blood gets pumped out. Watch what happens when we don't allow the body to decompress and allow the chest to fully recoil. The heart does not have a chance to refill with blood. Therefore, no blood gets pumped out. So remember, the key purpose of delivering compressions is to keep oxygenated blood moving within the heart and up to the brain to keep the brain alive. We need to push hard and push fast in the center of the chest. If ribs break, that's okay. What's not okay is allowing the brain to die from a lack of oxygen. So remember, you are their only hope. Do the best you can, and don't give up until medical help arrives or an AED is present. You can do it.
You can do it. You can do it. You can do it. All right. So thank you so much for joining the class, for joining this free session. Let me know if there are any questions. You are ready to receive any questions that we have, or any appreciation or whatever you want to say. If you are ready to join the full section too, you can let us know as well. So thank you so much. Any questions? Any questions? Any questions?
Thank you, Doctor.
Thank you too for joining. Let me know if there are any questions. Let me know if there are any questions. You can put it in the chat. So someone is asking, so what if the person doesn't respond to the CPR? So if the person doesn't respond to the CPR and there's a qualified personnel available, the qualified personnel can declare the person clinically dead. Is that okay? Are we okay? So once the person declared clinically dead, then we need to inform the morgue and perform last office. Is that okay? So how do you coordinate and continue CPR? How do you coordinate and continue CPR when patient starts aspirating in the process, and if there's no specialist available to secure an airway? All right, so when you do the full course, they will let you understand that there are various airway agents that you can use. There's the oropharyngeal airway, nasopharyngeal airway that is used to temporarily secure the airways of the patients to prevent aspiration. Is that okay? And the laryngeal airway, which is also a definitive airway that can be easily passed, even when this one is not, when the anesthetic is not around. So we will teach you how to pass a laryngeal airway, which is also a form of a definitive airway, which is very simple to pass. Okay, so that is also something that will prevent the patient from aspirating during the CPR. Okay, so I actually advise everyone here to join a full training session. So the paid course, we will put the registration. I think on Monday, or later, by maybe tomorrow or Monday, we put how we go about. You guys can go about the registration on our WhatsApp page. Is that okay? So that you know about how to go or about the registration as well. So I'll send some forms, Google form out, so that those who are interested can fill the form. We get your emails. We send you some email on how to go about the registration. Is that okay? Yes. So the early bird, which is 72 hours to 48, 72 hours after we've posted the forms of registration, goes for 250 cedis for both ACLS and BLS training. And then those who register after the 72 hours will pay 300 cedis for the course, which is, it comes with certification as well, which you can use to boost your portfolio. So that everywhere you go, they know that your boss know that you've had some sort of BLS and ACLS training as well. Okay, so don't. It's a very, very worthy course to have to go through. I admonish everyone to take advantage. All right, so could you please tell us about the page on how to register? Okay, certification. Okay, so certification, you get your certificate afterwards. All right, so someone says thank you. What do you do if SIM is not safe and no time wastage? If SIM is not safe, please don't go ahead with CPR, okay, before you fall as a victim yourself. Okay. Thank you. Someone says thank you here. So for the full course, there are some practical scenarios, that's real life scenarios that will be discussed during the full course. It will be virtual, but yeah, so it's fully virtual. It's the whole thing is an online course. If you want a practical section, you can let your maybe administrator or your hospital nurse contact us. So from August ongoing, you'll be going to hospitals that will contact us for practical sessions for training. That one will come with training equipment to help you solely have the practical sections. Okay. All right. So have your practical session. So it's a fully virtual course. Okay. Someone said very good presentation. Thank you. All right. Thank you too. Thank you too. Thank you so much. Okay. So if there are no other questions, thank you so much for joining the presentation. If there's any question, you can ask in the chats and we are ready to answer you. As the WhatsApp chats, our WhatsApp community, official community, you can ask any questions, you are ready to answer. And those who pay for the full session will be added to a special page, the cohort 2 page, and discussions will be ongoing, and however the course will be running will be told to you as well. Thank you so much, and God bless you for joining us. Have a very good evening. Enjoy yourself. Thank you. Bye-bye.
Bye.
You can put some appreciations on in the chat as well, even as you go off the page. Thank you so much. Thank you so much. Thank you. No, you don't need ECG before CPR. Okay, you don't need ECG before CPR, exactly. But after CPR, when the patient, when the AED is connected, you don't do ECG before CPR. The AED or the defibrillator will give you it will give you the radium strip, which is lead 2. That's what is in the AED or defibrillator, so that you can know what's happening in the heart of the patient, electrical activities, everything ongoing. Post cardiac arrest care involves you taking a ECG for the patient, and you can do other labs. Is that okay? But don't waste your time to go and do ECG. So by the time you come, the patient, you start CPR, is gone.